Hi, good afternoon everyone, and thank you for tuning in. My name is John Latchford. I'm from the UK Men's Health Association. As the video just showed us, there are more than 47,500 men are diagnosed with prostate cancer every year. That's 129 men every day. So every 45 minutes, one man dies from prostate cancer. That's more than 11,500 men a year. 1 in 8 men will be diagnosed with prostate cancer in their lifetime. Around 400,000 men are living with and after prostate cancer. These statistics are from Prostate Cancer UK, the leading charity in this field. Their top priority is funding research to stop prostate cancer killing men. What would you say if a friend, a son, or perhaps even you were diagnosed with prostate cancer? What options are open? Does this mean you or your son-in-law can't have children now? All these questions might keep you up at night. So what follows is a lively chat, we hope, between our own Dr. Chris Manning from Sheddington Shed in Teddington and our world-leading Professor Mark Emberton, who's from the University College London Faculty of Medical Sciences. It will bust the myths and provide a listener-friendly explanation into prostate cancer diagnosis and the treatments available. Standing shoulder to shoulder, as we talk about in the Men's Shed movement, you can achieve so much more, adding years to life and life to those years. This is an interactive session you can follow through Facebook, YouTube, or the UK MSA website. The first 30 odd minutes will be an interview between Dr. Manning and Professor Emberton, followed by a question and answer session open to everyone watching. We look forward to your questions and messages. To comment or ask a question, you'll need to be signed in to your Facebook or YouTube account. Now over to Dr. Chris Manning and Professor Mark Emberton. Thank you, gentlemen.
Thanks very much, John. That's really great of you. And I'm absolutely delighted to be here. It's the first time I've done anything like this, so I hope you'll all be patient with me. I look a bit like an airline captain, but I'm feeling a bit wobbly, so bear with me. It's absolutely great to have Mark here. I heard him present about 5 or 6 years ago at an event up in London, and it's stayed with me completely. So when we started talking about prostate cancer as part of what we're covering in the Health and Wellbeing Advisory Group at the Men's Sheds Association, I thought, who better than to actually get us right into the jump seat and to understand this condition and the amazing amount of research and activity there is now around it, and quite rightly too, in view of all the statistics we're hearing. So Mark, I was wondering, welcome, and thanks for doing this so much. I was wondering if we could just start off with talking about the biology of prostates and prostate cancer.
Well, yeah, of course. Can I just say thank you for inviting me and giving me this wonderful opportunity to meet you both, and indeed all the others who are on this webinar at present, and also to get to know the Men's Sheds Association. It wasn't an organisation that I was aware of beforehand, which is my error. And what a wonderful organisation it is, and I hope to get more and more involved with the organisation in time. So I think that's a good place to start, Chris. So the prostate is a funny organ. It sits just behind the pubic bone, which is the kind of hard bone down between the legs. It sits just below the bladder and just in front of the rectum. So it's a difficult organ to get at. And because it has bone in front, water above, and air or solid behind, it's been a very hard organ to actually image. So in other words, to do x-rays of and get any idea of what's happening within it. All men are born with a prostate, and provided puberty develops in a normal way and testosterone, the male hormone, is excreted in adolescence, the prostate begins to develop and grow, largely due to the increase in testosterone. The function of the prostate is to produce semen. Many of the problems associated with the prostate relate to its position and to the fact that the urethra, the water pipe, goes through it. They say a river runs through it. And the growth of the prostate can indeed impact on the passage of urine. And that's the most frequent symptom that men will start to notice as they reach kind of midlife, usually 50s, 60s, and 70s. And that's because the prostate is growing, That's not a cancerous growth, that's a benign growth of the prostate. And it's an unusual thing because as we get older, most of our organs shrink and get smaller. The prostate, however, gets bigger. I think the only other two areas that get bigger are the nose and the earlobes with aging. So the prostate shares something with the cells of the nose and the earlobes. Now, during that process of benign prostatic hyperplasia, the words don't matter, but that's the biological process of the benign growth of the prostate. Most of us will develop cancerous cells in the prostate during those decades from 60 through to 80 through 90. If you are lucky enough to make it to 80 or 90, it's almost invariable that we will find prostate cancer cells in the prostate. And indeed, many studies were done years ago now of men who died of other things, and we looked at the prostate and found cancerous cells within it. These cancer cells hadn't caused these men a problem and probably were never destined to do so, but that allowed us to define the natural history of these cells. And by far the majority of prostate cancers will not result in problems and will not result in a premature death of that individual. However, some will. We've just heard the statistics, and some men, sadly, will develop low-risk cancer, which can morph into higher-risk cancer. In other words, cancer that can spread and result in a prostate cancer-related death. And other men, just out of the blue, will develop aggressive cancers that can grow rather quickly and spread before we can identify them. So you can see the problem immediately. Prostate cancer is very common, but it doesn't cause problems in the majority of individuals. However, some individuals are destined to develop and do develop aggressive prostate cancer that can quickly spread into the bone and lymph nodes. And once it spreads beyond the prostate, it is largely incurable, though I've got some good news on that. And so ideally we want to try and identify it early before it does so. And we want to identify those cancers that are likely to cause problems, not the ones that aren't. So I'll stop there, but that's essentially the natural history of both the prostate and prostate cancer.
Wow. There's a lot going on between our legs, isn't there? It's a very crowded space, which must make things very challenging. So I was wondering, in the light of that, I mean, how do you go on to sort of pick out, to be more sort of accurate and specific in terms of knowing what you're getting into before you get into it, with the imaging and all the other things that are now available?
So this is a good news story. In fact, most of what I'm going to say is a good news story. When I was training, the only way to identify that a man had prostate cancer was to put your finger into the rectum and feel the back bit of the prostate. You can't feel all the prostate from the rectum. You can only feel what we call the posterior element, which is basically the back of the prostate. And so if you had prostate cancer in the front of the prostate, you couldn't feel it. Once I qualified, PSA came about, and PSA stands for prostate specific antigen. Many of the men and indeed women listening to this now will know what that is. That's a blood test that alerts us to the possible presence of prostate cancer. PSA, or prostate specific antigen, is not cancer specific, but it's prostate specific. And is a substance. Its role actually is to liquefy semen, and that's its role. It's an enzyme, what we call a serine protease. But if there's a disturbance of the prostate, greater amounts of that enzyme can leak into the blood. And by disturbance, I can mean a very long cycle ride over cobbles, an infection, or indeed prostate cancer can do that. And the PSA is elevated. And that makes us, that increases the risk of that individual having prostate cancer, but does not guarantee it. And of course, some prostate cancers will develop without raising the PSA. So just like the COVID test, we're all experts now on false positives and false negatives. So we had the finger before, which is an invasive test. Many men didn't want to be examined in that way. Comedians made jokes about it. And it wasn't a good test anyway, but that's all we had. And then we had this blood test, which was much, much, much better than the finger, but was pretty blunt in that it didn't identify all the cancers. And it did mean that many men had to go on to biopsy who didn't have prostate cancer. So that was the false positive element. And then, of course, the breakthrough, and this is something to be very proud about, because this is a British UK, if we're going to be nationalistic for the moment, I'm not usually, but it is something to celebrate. So the revolution of MRI in the prostate, which has changed completely the diagnosis, and I'll go into this a bit more in a minute, I'm sure, was largely a phenomenon that we developed here in the UK through the NHS, and the first use of MRI to identify prostate cancer was done here in the UK, and all the key studies that have changed the way that prostate cancer is managed throughout the world were again done in the UK.
Wow. So, but I mean, there's no cancer other than the prostate cancer that's not priorly sort of imaged with biopsy, is there? I mean, prostate cancer still seems to hold out for a lot of people. Is still not getting this. They're getting that. You know, how many people are getting this sort of treatment or this investigation with the functional MRI and so on?
So I think in the UK we're lucky because NICE, the National Institute of Clinical and Care Excellence, they keep changing their name, approved MRI for all men prior to biopsy. So if you were considering or being considered for a biopsy, it is now the standard of care for all men in the UK to have an MRI beforehand. The UK was one of the first countries in the world to insist upon this. I think we were just pipped at the post by Norway. And so we're in a really good place. Now, I had a call with some American colleagues the other day, and they were saying that it's really hard for men to get an MRI scan in the USA, which is incredible to hear. And that means that they have these random biopsies that are invasive and miss half of all the cancers, and they misdiagnose the other half.
Do they spread it as well whilst they're doing the biopsying?
Well, yes. I mean, one always worries about that. And if you're biopsying something randomly, you're biopsying something inefficiently, and you're not targeting the bad tissue, and you're largely interrogating the healthy tissue. So there are concerns about that. So the beauty about MRI, and I mean, this will be obvious to everybody listening here, is that MRI tells you where the cancer is. So it allows you to put the needle directly into it in the same way that you would have a CT scan for a brain cancer, or a lung cancer or a liver cancer. And not only does it tell you where to put the needle in, it tells you how big it is, it tells you how many there are, it tells you where it is. So what's it close to? The rectum, the nerves that mediate erectile function, the urethra that through which you pee. So all these structures are really important and will inform how best to treat that individual if that individual does indeed need treatment.
So do you think there's any room now or space for people to self-examine themselves, or do you think there's any point at all in doctors and GPs getting people to leap up on the couch and for them to put their finger in and fiddle around? I mean, it seems to me that might be what people expect, but it doesn't seem to be sort of very scientific any longer.
I agree entirely. I mean, we know actually from a performance perspective, in terms of accuracy, the digital rectal examination of the finger is close to useless. And the reason for that is relates to what I said earlier, that the prostate's growing, and it grows asymmetrically, right? And therefore it can feel abnormal when it's not, which creates red flags when there shouldn't be red flags. And equally, many cancers are now known to be anterior, so well beyond the reach of the finger. The other thing about the prostate is that it's unique to the individual, right? It would be perfectly legitimate to run a prostate scan at Heathrow Airport to identify the individual. It's as unique to the individual as your fingerprint or your iris.
Wow.
I have radiological colleagues who know patients through their prostate MRIs. They don't know their names, but I remember this one from last year. And because every single prostate is completely unique, which makes declaring normality very difficult, particularly if you don't do many digital rectal examinations. So if you're a well-meaning, exceptional GP, you're not going to get that much opportunity. And so discriminating the abnormal from the natural variation is very, very difficult. I mean, even for me, I do this all the time. So the MRI is by far the best test.
And I'm used to getting a test coming through to check out for colon cancer every few years. And I'm just wondering, what's the place of sort of actually screening for prostate cancer, if and PSA and all the rest of it? What's going on there?
It's a great question. So the PSA story was unsuccessful. So there was a huge amount of investment, and many men were recruited. Many thousands of men were recruited into trials in Europe, UK, and America to see if PSA and random trust biopsy could identify men at risk of premature death. And the answer was a kind of a no, essentially. And there aren't. I think there aren't many countries. Latvia, I think, might be the only country in the world which has and don't quote me on that, but there is one country that has formal prostate cancer screening, but most countries don't, because of the harm done from existing screening strategies, because of false positives and false negatives. And so that's not that. To me, that doesn't mean we shouldn't have a screening study. That just says we use the wrong screening tools.
Yes.
And I think we now know that. We've just completed a study, and colleagues have just published another study using MRI as a screening tool. And this is a short sequence MRI. So this is a 10-minute scan, essentially. The other thing about MRI that people should know is that there's no radiation, right? So there's no harm from being exposed to radiation. It can be a little bit claustrophobic because you're in a quite tight tube. It's quite noisy, despite the headphones they give you, but there's no known harm of being exposed to a bit of a magnetic field, and so it's an ideal screening test because MRI machines are everywhere. If you start using them more efficiently and you reduce the scan time, I think we could have a really good screening tool for prostate cancer.
Gosh.
We've just completed the study as part of the Reimagine study, which I lead. This is a big investment from the Medical Research Council, which is taxpayers' money. So you've all paid for this, and that we had 6.3 million, huge amount of money to develop a big MRI study, which had a screening component. We invited men to come for an MRI check through their GPs. They did, and we're just analysing the results now. We'll soon be publishing that, and we'll use that. Or the data arising from that study to inform a much bigger screening study that will probably be conducted throughout Europe and the UK. But I think we would like to lead that, again, from the UK. And I think that'll be very exciting because MRI doesn't miss any bad cancers and overlooks the cancers that don't matter. So it has the perfect attributes. If I had colleagues here, they would criticize me. There is no such thing as the perfect test, but it's amazing how perfect it is in terms of its calibration.
Thank you very much. I'm just wondering, moving on from diagnosis and so on, how do you go about staging people or working out what the next steps are going to be if you pick up cancer in the gland?
Yeah, it's a really good question. So this is what I call the risk stratification bit. So whether we decide whether the prostate cancer merits treatment, whether it's confined to the prostate or not, and if not, to what degree. So this is kind of knowing your enemy, and we use a range of things. The PSA gives you a kind of indication. If your PSA is less than 10, the chances of spread beyond the prostate are very low risk. The type of cancer, in terms of how it looks under the microscope, is really important, again, in determining the likelihood of spread. And this is a little bit complicated, but men who've been through the process will know what I'm talking about. And there's something called the Gleason score. The Gleason was just a pathologist, but the important thing is that there are three numbers, and it's odd because it's 3, 4, and 5. We used to have 1 and 2, but we got rid of them for various reasons. 3 is the pussycat, 5 is the tiger. So 3 nobody dies of, 5 is bad because it invariably spreads, and 4 is the kind of in between. Fortunately, 5 is rare, and so most of the risk stratification is about how much 4 is present. And then the other thing that we're increasingly using, so far we've got PSA, we've got MRI, which gives us tumor volume, location, etc. We've got information on the type of cancer, so the grade of tumor, the degree of aggressivity that the prostate cancer is exhibiting. And now we are using scans such as PSMA scans, and these are nuclear medicine scans that look at antibodies on the prostate cancer cells on the membrane, and are really, really sensitive and specific at identifying cancer that is spread beyond the prostate.
Wow.
And actually, we're finding, we used to use bone scans and things like that, and we're seeing bone scans that are negative, but PET scans that are very positive. And so this is yet again improving the manner by which we can correctly classify an individual and therefore correctly allocate the best treatment for him, because we're less likely to be wrong now than we were 5 to 10 years ago.
It's absolutely amazing what's happening. I mean, just to see this all happening in my lifetime is quite remarkable, and not a little humbling, it has to be said. I mean, as part of my reading for this session, I sat through an amazing group. There were 4 American experts talking about this yesterday, and I was absolutely amazed. I mean, I could understand about every sort of 40th word, because there were all sorts of trials going on. There was ASCO, A6 trial, RPFS, PCA, lutetium, targeted radionucleotides, and all sorts of things happening going on, especially around the sort of genetic mapping or immune, studying immune cells and the inflammatory pathways and so on. And so much of that is all coming together as well, isn't it, as a result of sort of COVID and all sorts of other things that impinge on our inflammatory processes and immune processes within the body. So, I mean, how do you go on from getting all the scan results and the degree, knowing about the sort of knowing the enemy, as it were? How do you move on to the next stage in terms of deciding, what intervention to deploy? Okay,
well, I think I'll answer that in another way. So I think we've talked about the MRI development, and then I'll come back to a question which I think is very good. The other big changes, you say in your lifetime, but also mine. I've been looking after men with prostate cancer for close on 20 years. Dramatic changes. If cancer had spread beyond the prostate, basically we tried to keep them comfortable. That's what we did. And now we've got a whole complete new array. No, actually, I'll tell you another anecdote. So one of my jobs when I worked at Ashford Hospital with the late Brian Ellis, who was my great mentor and role model in urology, was to just remove men's testicles, because that's all we could do if the cancer had spread to the prostate. And I would have 8 names on my operating list on an afternoon with bilateral orchidectomy next to them. And that's what we did. You took away all their testosterone producing apparatus. The prostate cancer would be treated and would kind of melt away for about 18 months, but then would come back because the cells, just like COVID, finds a way around. It mutates around the impediment. And there was nothing we could do about that. But now we've got this whole, again, UK discovery, and this time the Institute of Cancer Research identified new hormonal treatments that actually could be used in the castrate-resistant phase. So when traditional treatments fail to work. So we had this new layer of treatment that could keep people free of disease for many, many more years. And then we discovered new chemotherapeutic agents that we could use, and their use would result in a prolongation of life. When I was training, we used chemotherapy as a palliative thing. Just if people were in terrible pain and we couldn't deal with it, we gave them chemotherapy. But nobody was of the expectation that it would prolong life. And today we're using these a lot earlier, and they are prolonging life. Now, the big discovery recently is that we can augment the body's immune system. And these are men who have failed every treatment we've talked about so far. And their PSA is rising despite all the treatments that we've discussed so far. And there are immune treatments that can result in a flattening of the PSA and a non-rise of PSA for a year and a half to 2 years, possibly forever, right? We can't say that yet because we haven't been following them up for that long. So we're getting complete remission. In other words, what looks like a cure, but we can't be sure that it is as yet because we need to spend more time watching the patients, in men who were previously incurable. Now, the trouble is that we can't do that very often. And it's about 1 in 20 patients at the moment that respond well to that type of treatment. Now, these are men who may have had their prostate removed, they may have had radiotherapy, they may have had hormones, chemotherapy, and then they're told their PSA is rising. So these are men who've been through a lot, and usually over a couple of decades. But it looks as though we're getting into an era where we'll have something else that really works, and that actually we might bring forward and use earlier prior to chemotherapy. And there's a kind of interesting story here, and it relates to BioNTech and the COVID vaccine. I mean, the COVID vaccine was developed by BioNTech, who are actually trying to develop vaccines against cancer. And they've got a prostate cancer vaccine that they developed long before their COVID vaccine, wow. Which in fact we are trialing it. My colleague Mark Lynch is the lead investigator on that, and we're trialing it to see if we can vaccinate men against their prostate cancer. And actually, it was that expertise that BioNTech had in Germany that allowed them to transition or pivot very quickly to COVID-19. So it's the kind of people don't know that. People think they were a antiviral vaccine company. They weren't. They were developing vaccines against signals on the outer membrane of cancer cells, and that expertise allowed them to use that to develop a vaccine against the signal on the spike protein of the coronavirus.
As a biochemist, or before I did medicine, I'd have to say that's totally inspiring. It's the sort of thing I used to dream about when that would actually come along. And you're also doing some amazing things with ultrasound and other treatments for nobbling these nasty cells. How do you do that?
Yeah, you've done your research. Very impressive. So,
well, I remember your lecture. It was that good.
This is my area of interest, and I'm very grateful to an extraordinary team that I've had the privilege of working with over the years, and they include engineers and physicists and radiologists and methodologists of all types. So, and it was really as a response to imaging, Chris. So, if you didn't know where the cancer was, you had to treat the whole prostate. Yeah, so this is equivalent to doing a mastectomy in a woman because you didn't have mammography, and that's how men were treated for 100 years. So the first prostatectomy was done by Hugh Hampton Young 100 years ago in Boston, wow. And we've been treating the prostate in the same way conceptually for 100 years. MRI changed that because it told us where the prostate cancer was. Once we knew where it was, it wasn't beyond the wit of man to direct energy to something that is often the size of a pea and selectively destroy it as a day case procedure in half an hour. And then the man walks home an hour later with no side effects, or very few side effects. And that was a birth of focal therapy. And that's about 10 years in gestation now, and it's not quite routine everywhere, which saddens me a bit, but it's widely available as long as we catch the cancer early. And so if we catch the cancer when it's about the size of a pea, and so that's about kind of 5 to 8 millimeters across, it's very, very easy for us to apply some energy to that using sound waves, electricity, ice, So it doesn't really matter how we kill the tissue. And we can do that selectively, and that doesn't impact on continence. It doesn't impact on sexual function. And it means that the patients can avoid hormones and 30 days of radiotherapy or major surgery. Now, if the patient has disease occupying both lobes of the prostate and it's kind of everywhere, focal therapy is not appropriate. That patient needs the equivalent of a mastectomy if we were talking about breast cancer. So focal therapy is the male equivalent of the lumpectomy that is available to about 80%, I think, of women that present with breast cancer. And that has revolutionized the management of early prostate cancer for some men.
Oh boy. No, I mean, we're kind of romping at this, and I'm just wondering if there's anything that I could have asked you that I should have asked you or could have asked you that we haven't covered just for this section before we go to everybody else's questions.
I think that's everything. The only area we haven't covered is this notion of surveillance. So, and many men, rather peculiarly, may be diagnosed with low risk prostate cancer and told. In fact, I had this conversation yesterday with somebody, and they didn't understand what I was trying to say. Probably my poor communication skills. But he had low risk prostate cancer. This is the Gleason 3 number now, and we were pretty sure that there was nothing else in his prostate. And I said, well, this is unlikely to cause you any problems during your remaining life, and therefore it's very reasonable to watch it. And he said, but I want treatment. And I said, fine, we can certainly treat you, but you will not benefit from it. All you will experience is harm. And if I can't benefit you, all I can do is harm you. And that's not something I particularly want to do. So we had a detailed discussion and about monitoring his prostate very carefully with PSA and MRI. And what we'd be looking for there is changes in the prostate cancer by its PSA secretion or by what we could see on MRI. And that would be very similar to watching a small skin cancer. And I'm sure many of the men and possibly women listening to this will be seeing their doctors regularly who've had a bit of sun exposure, and you watch it, and then if it starts to turn a bit nasty, then you go to the dermatologist and have it taken off. And that's very similar to the process of surveillance, and that's been transformed by MRI because we can actually watch these lesions very, very closely over time. And they might be some men listening to this who have a yearly MRI with, ourselves or colleagues, and then they're just reassured every year, and then see you again in a year with an MRI. And that process of active surveillance, I think, is quite an important one.
If I might just ask you one more question. It relates really to the availability of these interventions, across the whole NHS, really.
Yeah.
And how, NICE says a lot of things depend on, they're implementing various pathways and so on, but depending on local expertise in all the reporting, of histology and all the rest of it, and protocols and availabilities of treatment. So what's your sense of how, any of us going into our particular GP in our particular hospital settings are going to get something around what you're talking about, or better still, definitely getting what you're talking about?
So I think in general, we're in a really good place in the UK, largely because of the reformation of cancer services that took place about 5 to 8 years ago, and this was the quality and quantity issue. So if you concentrate services in one place, you get much better quality of care because the expertise is much higher. And I remember it was a difficult process telling local inhabitants that the local hospital weren't offering prostate cancer services and that they would have to travel to the big hospital. Didn't go down well. And I remember going to town halls around London when this process was being talked about. And it was pretty hostile because nobody likes to have local services shut down. Anyway, it's happened. And if a man is unfortunate enough be diagnosed or be at risk of prostate cancer, he will be referred to a centre of excellence that will be regional. And for instance, at UCLH, all the prostate cancer treatments done in North London, I work in North London, come to UCLH. So we have very high throughput. We have lots of experts. We regularly meet. We do lots of research, etc. And so you have this a lot of quality there. And so the chances are that you'll get much, much better care than had you gone to your local district general hospital, despite it being very good, and be seen by a urologist that does lots of things, including prostate cancer. So I think actually we're better off than most countries in the world in terms of the concentration of services. Now, not all the innovations that I've discussed have disseminated everywhere as yet. And I said already that that's been a frustration of mine, and it remains so. And the very specialist offerings, some of which I've talked about, such as immunotherapy, such as focal therapy, are available in only certain places, and you need to be pretty proactive to get referred to them, because if you don't mention that you want to be referred to them, you might not get offered them. And I have a lot of emails and a lot of people contact me who want to access these services, and we then ask for a GP referral. So, you know, the world isn't evenly spread, and it takes time for new things to disseminate, and that some of that's entirely appropriate because you want to develop the expertise and the knowledge first before going wider. Some of it's just inertia. You know, and certainly, yeah, things like COVID don't speed up that process because of the distraction of having to deal with something else.
Yes. Well, that's a terrific roundelay of answers, and we move on to some questions now. So I'm just ready for questions. Who's going to ask the questions? Here we are. Here's one from someone, a friend of mine. Are there encouraging advances in the screening for prostate cancer? Yeah, I think you've talked quite a lot about that already. What other things are there anything we've missed?
So that's a firm yes. My personal view, and this is not shared by everybody, is that imaging is going to be the solution to this. And the reason I say that is that people may have heard about these multi-cancer tests, these blood tests that are meant to be able to identify lots of cancers. Some got in the news. Grail, I think, was the last one in the news. And these are tests that look for cancer-related circulating DNA. So little strands of genetic material that the cancers shed that we pick up in the blood. And prostate hasn't done particularly well with these tests. And there's a huge hope for these tests. I don't know. I'm skeptical about whether they will prove to be good screening tests. There are lots of issues with them, but prostate in particular, I think, will not lend itself to these multi-cancer blood tests. So I think imaging is ready. The developments I haven't talked about. So I've just talked about short MRI. But we are developing sequences at UCL now that will take 4 minutes. So these are new sequences that are tuned to detect prostate cancer, that should take 4 or 5 minutes only to run. And so, you know, you could do 5-6 patients an hour on a scanner, which completely transforms the offering. And actually, we could run a screening program with just a few scanners dedicated to prostate, placed throughout the country. So lots and lots of development. AI, I haven't mentioned AI yet. How can you give a talk without mentioning artificial intelligence? So artificial intelligence is also being used to interrogate the images that we're getting on MRI to help us automate the process of detection. So in other words, to make it cheaper and make it more reliable, so we're not completely reliant on human beings to read all these things.
Thank you. Julie's asking, why is prostate cancer so much more prevalent in BAME communities?
I'm not sure we know the answer to that. It's complicated. So vitamin D was thought to be an issue. So if you've got darker skin and you live in off the equator, and you're indoors most of the time, then you won't be getting vitamin D. Vitamin D is kind of a big deal at the moment because it's thought to protect you from COVID if you get COVID by priming your immune system. That's been purported. There are some genetic predispositions that are slightly more prevalent, but that doesn't tell the story either. There may be some dietary issues that are important. There clearly must be, because as individuals move from South Asia to America or Africa to America, their prevalence or the likelihood of developing prostate cancer increases during one, possibly two generations.
The developed country diet.
Yes, so as you move away from a kind of largely vegetarian rural diet towards an American diet, things change. Now, lots of other things change as well, and so it's complicated, and we haven't pinned it. A lot of the work also is on black men, is American, and we need to replicate that in the UK. And obviously there are social class issues as well. So black American men on average can't access the quality of care than their counterparts can, and that's an issue. The one thing that I find very reassuring is that in studies where black men do access high quality care, and that's taken care of, the differences largely disappear. So not completely, but largely disappear. And that means that this has a solution, that it's not necessarily inherent, but it's complicated. It's a real effect, but I think it goes right along the pathway.
Sean Farrington says, yes, what you say is correct with this treatment. Perhaps we need to ask him which treatment he's referring to. But if the cancer comes back, you cannot operate and you're doomed. Perhaps we should ask Sean which treatment he's referring to. Could we do that? Stephen?
I could probably have a stab at that.
I think. Stab at it? Okay.
Yeah. So as in all cancer, your first treatment defines your second treatment should you need it. No treatment works in everybody. I mean, surgery doesn't work in everybody. You'd think that it would, but it doesn't. And about 20% of men need radiotherapy after surgery to mop up cells that are still in and around where the prostate was removed. Obviously, if you do surgery, you can't repeat the surgery. You can only do surgery once. Radiotherapy is the same, because the radiotherapist aims to give the maximum tolerated dose in one go. So it's quite difficult to repeat radiotherapy. There are some circumstances in which it can be done with brachytherapy, but that's kind of fairly challenging. So the treatment
what's brachytherapy?
Brachytherapy, good question. Brachytherapy is a way of administering radioactive pellets into the prostate, and so instead of shooting from outside, external beam radiation therapy, you have a source that you put in the prostate, which is either permanent or temporary, depending on the type of brachytherapy, that delivers the source from inside the prostate. Yep. And it's just another way of delivering radiotherapy, really. So there are some treatments that you have that dictate what treatment you will have next, should you get a recurrence. With focal therapy can be repeated. So this Stephen's question now, there is no what we call cumulative toxicity. So sound waves and ice and things like that can be repeated. And I tell men there's about a 10% chance they'll need a second treatment over a 5 to 10 year period. Now that could be to the same area, or it could be to a new cancer that develops elsewhere in the prostate.
Here we are, there's one from Fraser Young. Having had male breast cancer, what's the chance of prostate cancer developing, given it's all hormonal?
So they're not linked. Obviously, breast cancer in men it's quite rare. Prostate cancer in men is quite common for all the reasons I said earlier. Breast cancer and prostate cancer are linked in families with the BRCA2 gene. So the BRCA2 gene, which typically families who have a lot of ovarian cancer, breast cancer, and prostate cancer might have this gene in the family. Fortunately, that gene is quite rare. And that's the gene that resulted in Angelina Jolie having bilateral mastectomies because of the inherent risk associated with that. But I think for an individual who had breast cancer and there's no strong family history, the chances of prostate cancer are unaffected.
As a matter of interest in scientific investigations, is it helpful that the exception proves the rule? So when you have people with a rare abnormality and they display a whole range of different sort of pathological problems, because they're not so common, you've got less sort of factors to consider. You can actually get a group of people with the same issue and study them in great depth. I mean, like it happened with HIV and AIDS, it was the people who didn't go on to get AIDS with HIV who kind of had enabled a lot of the pathways to be worked out.
Absolutely. And it's often that anomalous, unexpected result in science that gives you the insight into mechanisms. So you can ask the question, why did that happen? What is it about this individual that resulted in this change occurring? And that observation is a key one in science. In fact, just yesterday, I had a PhD student, and we're developing a new treatment for prostate cancer. And we've been running it along cell lines, and it seems to destroy all the prostate cancer cell lines. These are kind of artificial prostate cancers that we can work with in dishes, what we call in vitro. And then suddenly we tried a different cell line, it didn't work. And he was very disappointed. And I said, no, this is a gift. This is an opportunity for you to really find out why it didn't work. And actually, it's going to change your whole thesis, your whole PhD. Yep. This could result in a Nobel Prize. You never know.
Yes.
That single observation, but the key thing is the scientist has to respond to it in the way that Fleming responds to his contaminated dishes. He didn't throw them away.
No.
He paused for a minute and said, "Why?"
Yeah, that's very profound. Stevie's asked if should they have a PSA blood test as a matter of routine, which comes back to what we discussed earlier about screening and so on, I think. But perhaps just to reiterate that.
I think it all helps. I think if your PSA is very low, less than 1, it's incredibly reassuring that you don't have prostate cancer and indeed are unlikely to die of prostate cancer during a remaining life. We got reasonably good evidence on that. Based on old Swedish studies that had blood tests taken, and we found out what the people died of. These were cardiac studies done in the 70s, and the blood was analysed for PSA. And if your PSA was very, very low, your chance of dying of prostate cancer was 1 in 3,000 or something, kind of almost close to 0. So PSA can be very reassuring. If it's in the grey zone, then the beauty is we've got MRI now to kind of sort it out. So you don't have to go straight to biopsy. And if your MRI is okay, you can be reassured. So I think there's much merit in doing PSA. Hopefully, in a few years, we'll have a better test, and all men every 5 years will have an MRI.
Yeah, I saw there's somebody being funded by the prostate charity over here in the UK who's looking into different types of sugars, I think it was something to do with sugars, but I thought that was interesting. And then, in fact, I went and asked for my PSA. I've had it done a few times, and it's always been below 2. So the GP didn't look at all sort of worried and said I could carry on, just as didn't have to have anything else done.
So 2's good. 2's good.
That was pre-COVID. Everything's gone AWOL since then. Now, why do you think there's still so much discussion amongst fellow professionals as to whether PSA levels are truly significant regarding clinical mortality risk and so on? Okay,
so there are 2 aspects to this question, and they get confused. So if you use PSA across a population, then you have to deal with the issues of false positives and false negatives. And it largely relates to the poor performance of the test and the fact that everybody's prostate is different. Different size, different shape, etc. So as a test across a population, it doesn't work very well. Now, in an individual, it works very well indeed, because obviously that doesn't change very much. So, if your PSA is 2 and you measure it again next year and it's 2, that's very reassuring. and the year after it goes to 3, and the year after that it goes to 5, you've got a strong signal, because the within patient variability is low, but the between patient variability is huge. And the reason is that some men listening to this podcast will have a gland that's the size of an olive, and other men will have a prostate gland that's the size of an orange. And you can imagine the different amounts of PSA that both those organs make.
Yes. And it was interesting what you said about everybody's prostate being different. And I was trying to, well, I sort of went off in a slight corner in my own mind about thinking about fingerprint recognition on computers, and wondered how long it would be before we use our bottoms for the Apple iPad to recognize us because of our prostate footprints. Here we go. Back to what we should be doing. Richard Cherry says, a friend of mine died from metastatic CA prostate about 15 years after an entirely successful transurethral prostatectomy. Is it?
Yeah. No, I can take that. So I'm very sorry to hear about your friend. It's difficult to know what happened. So two things might have happened. The TURP, for those listening, is basically we bore out the middle of the prostate to help people pee. It's not a cancer operation. It's to help people pee. So sometimes you do that, and the patient's peeing beautifully like a 20-year-old afterwards, and you analyze the tissue that you've removed, and it's all clear, but there could still be prostate cancer in the bit of prostate that remains behind. And 15 years ago, that was before MRI, and that might have developed and indeed spread. Okay, so that's probably the most likely story. So the two are independent. I don't think the TURP accelerated the cancer. I think they were done for different reasons. The other explanation is that your friend had advanced prostate cancer that had started to block the urethra, and the urologist then used the TURP to help relieve that. And the cancer was recognized at the time, and that individual then had treatments over the last 15 years that hopefully prolonged his life and kept him alive for 15 years as opposed to an earlier death. So I don't know which of the two occurred, but it could have been either.
Thank you. Oh.
We have about 5 minutes left to close out the hour. I'm not sure what your time's like, Mark, but we have about 10 more questions. Are you happy to stay and answer those questions? How should we go?
I'll have to leave on the dot because I've got another call. Yeah.
Okay, so perhaps we'll just race through these next few questions.
Made the point about early intervention. How does a patient recognize the transition from a non-cancerous enlarged prostate to the next stage?
Yeah. Good question. So the prostate enlargement is an independent process to the cancer development. Right? They both occur in men in their 60s. The median age for prostate cancer diagnosis is about 64 to 67. And so the prostate is growing during that time. And within that growing prostate, there are cancers developing in the majority of us. Not all of us, but in the majority of us. So it's difficult. You've got two things changing. Fortunately, MRI can pick up. I think MRI is the best test because it's not subject to all the vagaries of PSA, and it's not subject to the sampling error of prostate biopsy. And what MRI does, it exploits the fact that the cancer is different from the underlying prostate in nature, and therefore signal, and can discriminate between the two. And that's why I think MRI is such a good screening test.
Yeah, and that would presumably also be augmented by the use of AI to be able to get even finer.
Yeah, I mean, I think AI will eventually be better than the eye itself.
Yes.
And just like
AI.
Yeah, grandmasters could beat AI, in the beginning, but they can't now.
Yes.
So I think AI will do it, because ultimately an MRI is just ones and zeros. It's pixels. And AI can interpret subtle changes in pattern that the human being could never detect.
Thank you. What about the risks of biopsying, needle tracking?
Yeah, I think this is overstated. I think I get asked this a lot, as you can imagine. I've never seen tracking. There's a presence on the internet, which is why this gets it now. The tracking of cancer down a needle site does occur with some cancers, kidney cancer being the obvious one, bladder cancer is another one. I've never seen it with prostate. And remember, all cancers are diagnosed through biopsy, and that goes for lung, brain, eye, big toe cancer, whatever. And so we have no other way of making the diagnosis. The diagnosis is made down a microscope. It does need a biopsy. Now, I've got the Reimagine, the study I spoke about earlier, is trying to see if we can make the diagnosis without a biopsy. So can we use imaging, AI, and information from the blood and urine to give us all the information that we get on the biopsy so as to avoid a biopsy? So I would like to get rid of biopsy for lots of reasons, including the potential for needle tracking, but mainly because it's harmful and people don't like it, and it's costly, and et cetera, et cetera.
Thank you. I don't know what ED is.
So ED refers to erectile dysfunction, at least
Okay.
it does in the context that we're speaking today. The trouble with ED and BPH is they both develop in men as they age. They're very, very closely correlated to age. And so there may be underlying changes in the individual that result in both. And metabolic syndrome, in other words, putting on a bit of weight, etc., has been implicated in both. So there may both be phenomena of aging that have a common etiology. And therefore, unless you reverse that common etiology, i.e. by a rejuvenation pill, you may not be able to address the ED. So we can treat erectile dysfunction, and I think we're getting much better at doing that. But Stephen is quite right. ED and BPH have a very close association, largely driven through age.
All right, thank you. Just got time for a very quick one. Is there a link with prostate cancer and reduced sexual activity?
No.
Oh, there you go. That's a definitive answer. Nice to be happy with that one. One sheet of paper, one word on one line. Mark, honestly, thank you so much.
Great.
We've had an hour of really, thrown you in at the deep end and everything, and you come up with all these wonderful answers and all the latest information and loads of things to help us to feel really optimistic about, going forward with a very, very important condition, especially to those of us who run men's sheds, and also because we also have ladies and all other available genders coming to our sheds, and everybody needs to know how best to look after the person they love. And I was always impressed by your first presentation because you came over so humanely, and just bringing in the personalizing aspects of healthcare and how you get to know people as a result of the care you're giving them, and how we bring in the subtleties rather than having everything dealt with a sledgehammer. So look, thank you so much for your time, and I greatly appreciate it, as does the UK Men's Shed Association.
It's been my great pleasure, Chris. Thank you for hosting me on this wonderful forum.
Thank you. Bye.
Well, thank you so much, Chris, for inveigling Professor Mark Emberton to come and talk to us. I found it an incredibly clear exposition of the issues.
Well, that's what I remember about him. He was just so clear. When I heard him speak before, I don't know if I told you, I might have done, do stop me if I did, he was talking we met at the Royal Artillery Company, the Honourable Artillery Company up in Old Street, up in London, at their barracks, which are surrounded completely by offices, and there's this huge, great big football pitch area in the middle. And we were in the brick building, and the guardsmen were all having some ceremonial dinner, and they were all fantastically well dressed and everything else. And there were pikesmen walking by this open window. Well, Mark was giving his presentation by the window, so you could see the pikesmen walking by on the other side of it. And he happened to talk about needle biopsying of the prostate just as this pikesman came by with this thumping great needle. About a 10, 12-foot pike. And I thought, whoa, don't like it up with Mr. Mannering, and all that. But I never forgot it. And I one quick thing, I had a reason to ask him to see a friend of mine who was being told, he was in his 40s, who'd been told he needed a total prostatectomy. This is only about 7 or 8 years ago. And I said, well, that's a bit harsh. And I'd heard Mark's lecture, and I sent this friend of mine off to see Mark. And Mark he did his wonderful tricks with the MRI and everything else. And the next time I saw this fellow, he had gone on into a new marriage, and he had twin children. And that certainly wouldn't have happened if he'd had the total prostatectomy. So, I mean, that was something you don't forget, that sort of thing.
No. I mean, for me, I think it was a few things. I mean, I didn't know that every single prostate was so unique that you could actually identify them.
Well, imagine that, and having to lift your bum over on top of your computer to do, instead of using thumb printing, we do prostate printing. That would be really good, wouldn't it?
Maybe. And I didn't know that they carried on growing through life in the same way my ears seem to be growing.
Yes. Yeah. Well, that's true. That does happen. Yeah, definitely. I mean, that's one of the,
I think the other encouraging thing was, I mean, I've got many of my relations working in the NHS, so I've got quite a soft spot for the NHS, though I've never worked there myself. But was how much, the NHS derided in the States, but it's actually pretty flipping good at this.
Oh, it is. Well, if it wasn't constantly interfered with by all sorts of people who want to use it to build their power bases, and I mean, the sorts of people I'm talking about, and governments do exactly the same. They all have to come along and announce some fantastic new something or other and claim the credit for it. If we could get rid of all that pomp and circumstance and ego-driven behaviours, and if we could get rid of 5-year turnovers of our parliaments and get rid of oppositional politics and have a proper constitution, we stand a reasonable chance of actually getting, I've always thought of this about, for example, aircraft. I mean, aircraft are governed by the laws of aerodynamics. Yes, of course, we have rules and regulations that govern how they fly through airspace, but they stay up there because of aerodynamics. We don't need party politicians or HR managers or anybody else up on the flight deck to tell people how to fly the bloody thing. And if we stick to the basic patterns, they'll stay up there. And but no, it's got to be, it's our announcement, it's our bit of posing and all the rest of it. So that's why Mensheds is also so exciting, because it's all about community and neighborhood. I can't believe how much positivity it's injected into my life over the last 2 years. You're connecting to people locally.
Came out of that session was the aside almost about vaccines against prostate cancer being tested and coming from BioNTech, who produced one of the COVID vaccines.
Wasn't that brilliant?
Yeah, I never knew.
No, I never heard that. It's complete news to me too.
Hi there, gents. Before, as people are starting to, as we've come to the end of the event now, we wanted to promote something. I think, John, obviously we can continue to chat, but did you want to just quickly promote prostate cancer for those who are more interested? So
lastly, I'd like to say Prostate Cancer UK, who are a big supporter of and funder of cancer research across the UK. One of the things they do is as you can see it on the screen now, they produce virtual awareness talks online. So you could book one just for your shed. Teams of trade volunteers throughout the UK who could carry out talks to groups both large and small, from a minimum of about 5 people up to 100, and give you more information about prostate cancer. So that link's on the screen right now. Thank you everyone for your time and attention. I'd really like to thank Chris Manning for his help in getting this going. The recording of this interview will be available on the UK MSA YouTube channel in about 30 minutes after the end of the session. So thank you very much, Chris, for your
my pleasure, John. My pleasure. Sheds, yay!
Yeah, we will all get back in the shed soon, hopefully. Goodbye, everyone.
Bye.